Hello everyone. Today we will discuss about estrogen replacement therapy in the 5-mark short note series. So estrogen replacement therapy refers to the administration of estrogen hormones to women with estrogen deficiency used alone or with progesterone, which is called as hormone replacement therapy, to prevent menopausal symptoms and prevent complications. Secreted mainly by ovarian follicles, placenta and adrenal cortex, estrogen has three main forms. One is estradiol E2, estrone E1 and estriol E3. Estradiol is the most potent form during reproductive years. Functions of estrogen. Estrogen plays a very important role in the development of secondary sexual characters, regulation of menstrual cycle, maintenance of bone mass, presence of cardiovascular and urogenital health, and improves mood and skin texture. Preparation and routes. Natural estrogen. It consists of estradiol and conjugated equine estrogens, synthetic estrogens like ethinyl estradiol and lestrol, and the routes include oral tablets, transdermal patches, vaginal creams, and injections. Therapeutic indications include menopausal syndromes like hot flushes, insomnia, and mood changes, premature ovarian failure or surgical menopause, hypogonadism or Turner syndrome, and atrophic vaginitis and dysmenorrhea, prevention of osteoporosis. So these are all the areas in which it is indicated. The clinical conditions include menopause, which relieves the vasomotor symptoms, Turner syndrome. In case of this, it will help in inducing puberty as well as developing secondary sexual characters. In ovarian failure, it prevents osteoporosis. In atrophic vaginitis, it restores the mucosal health, and in hypogonadism, it stimulates sexual development. Therapeutic margin of estrogen replacement therapy. So ERT has a very narrow therapeutic margin. Small variation in dose may cause adverse effects, and use of the lowest effective dose for the shortest duration. Regular monitoring for cardiovascular and endometrial effects is essential. Metabolism of estrogen. It is well absorbed orally and transdermally as well as vaginally too. It binds to SHB protein as well as albumin. Metabolism include in the liver, it is converted from estradiol to estrone to estriol. It conjugates with glucuronic acid or sulfate for excretion. In enterohepatic circulation, it prolongs the half-life as well as the effect. So metabolic pathway, as previously suggested, as previously discussed, it is transformed from estradiol to estrone, which is reversible to estriol. In this step, it is irreversible, and conjugation and excretion through urinary or bile activity. The main hormone is estradiol, and the main metabolic site is liver. Metabolites include estrone as well as estriol. Excretion include urine and bile form, and therapeutic margin is narrow and needs very close monitoring. And duration of therapy, it is very shortest and effective duration. Combination therapy with progesterone in women with intact uterus. Coming to the advantages, it relieves vasomotor as well as urogenital symptoms, improves the mood as well as sleep, prevents osteoporosis and fractures, favorable for lipid profile by increasing the HDL and decreasing the LDL, may reduce colorectal cancer risk. Contraindications include it is absolutely contraindicated in carcinoma of breast and endometrium, undiagnosed vaginal bleeding, active thromboembolic disease, and severe liver disease. Relative contraindications include hypertension, diabetes, migraine, and gallstones. Adverse effects include nausea, breast tenderness, and bloating, endometrial hyperplasia or cancer if unopposed, venous thromboembolism, stroke, and risk can also cause that, gallstones and hepatic dysfunction, and possibly increases the risk of breast cancer. Monitoring and your alternatives. So it is once the estrogen therapy is initiated, a thorough breast and pelvic examination has to be monitored very frequently, including mammogram and pap smear, lipid profile as well as liver function test. Alternatives include raloxifene, tibolone, that is mixed agonist, and phytoestrogens, which is a mild natural compound. So estrogen replacement therapy remains a cornerstone for treating menopausal as well as hypoestrogenic states. It has a narrow therapeutic margin and necessitates individualized dosing and periodic evaluation. Understanding its metabolism, benefits, and risk ensures a rational and safe therapy for women. So to summarize, estrogen replacement therapy is administration of estrogen to treat hypoestrogenic states such as menopause, premature ovarian failure, or hypogonadism. The primary goal is to relief of vasomotor and urogenital symptoms and prevention of osteoporosis. Mechanism include it replaces with deficient estrogen, maintains endometrial, bone and lipid hemostasis. Metabolism starts with in the liver. It is converted into estradiol to estrone, which is irreversible, whereas estrone to estriol is irreversible, happens in liver. Conjugation with glucuronic acid or sulfate and excreted via urine as well as bile. The therapeutic margin is narrow and require lowest effective dose for the shortest possible duration. And its benefit include it improves the quality of life, increases the bone mineral density and lipid profile by increasing HDL and decreasing LDL. Endometrial hyperplasia, thromboembolism, hepatic dysfunction and long-term breast cancer risk are there as adverse effects. It is absolutely contraindicated in hormone-dependent malignancy, active thrombosis, severe liver disease, unexplained vaginal bleeding. Monitoring include regular mammogram, pap smear, lipid and liver profile assessment. Key points include individualized therapy combined with progesterone if uterus is intact, and review the treatment annually. I hope you have learnt from this presentation. Thank you for watching.